just to help provide some better guidance to providers that are now starting to increasingly use antigen testing for care testing. So really the key takeaway from this is to use these tests and interpret them correctly. It's really important to consider the pretest probability before using these antigen tests and also when interpreting the results, especially in the context of increasing community transmission as we're seeing here in New York. There are verbal, kind of written instructions in the health alert, and then the CDC has some accompanying decision algorithms that might be helpful as well. But really the take-home message is when you have somebody with symptoms that are consistent with COVID-like illness and you have a negative antigen test result, it's really important that you do a confirmatory lab-based PCR because there are, of course, a risk of false negative results with these. And while that patient is awaiting results, we would recommend that that patient continues to isolate until the lab-based PCR confirmatory results are available. And in addition, so for patients with a very low pretest probability, meaning they have no symptoms and no known risk factors, and they test positive on an antigen test, we do recommend to, given the occurrence of false positive results, we would also recommend a lab-based confirmatory PCR test in these cases as well. And again, the patient should isolate while awaiting those confirmatory test results. Next slide. And this is a special health advisory that our new Commissioner of Health released about 2 weeks ago for the health and safety of older adults and high-risk patients, and also applying to household members and caregivers of these individuals. And this advisory advises that these groups take increased precautions as COVID-19 continues to increase in the community. The main precautions we recommend are to avoid public spaces and gatherings and wear face coverings at all times outside of the home, including indoor and outdoor spaces. In addition, we advise not to leave home except for work, school, or other essential activities, including going to get COVID-19 testing or other medical care, or to perform essential care services such as going to the grocery store or pharmacy. And if you do feel sick and are in these categories, please do not, well, this applies to everybody. If you do feel sick, do not leave your home except for COVID-19 testing and other essential medical care. Next slide. And we did want to acknowledge the CDC recent scientific brief that they released in the first week of December on potential options to reduce quarantine period. And right now, I just want to give you the update. We've been getting a lot of questions about this. Both New York City and New York State are taking a close look at the current guidance that we have, and we're working very closely to ensure that we are aligned to have uniformity across the city and state. However, at this point, no decisions have been finalized, and so for now, the quarantine period in New York City remains 14 days. And if and when a decision is made to shorten that, we will be issuing guidance through a health alert or other methods. So stay tuned. But for now, it's still 14 days. Next slide. And another hot topic, especially over the last week. So the company Ellume had just received EUA, FDA emergency use authorization for a home-based test, which is done entirely at home and does not require a prescription. So this is an antigen test approved for use in both symptomatic and asymptomatic individuals, which is actually different than all the other antigen tests that are approved, which others are only approved for symptomatic patients. So this is also a new indication, which is great. There are, concerns about reporting with this kind of model. So this has an interesting new innovation in that the small card where the test is performed has a Bluetooth connection from the analyzer to a smartphone app. And actually, the results are only reportable or readable through the smartphone app. And the results come within 20 minutes. And it requires entry of zip code, date of birth with some other optional fields, and then the app reports those results to public health authorities. And just to highlight, in asymptomatic individuals and people without symptoms, it still correctly identified 91% of those who were infected and 96% of those who were not infected. And in symptomatic individuals, it was even better, with correctly identifying 96% of those who were infected and 100% of those who were not infected. And the cost is planning to be about $30 per test, and the production is going to be ramping up in earnest in January. And I also just wanted to note that Abbott, who makes the Binax Now COVID antigen test, which is another card-based format, they also just received emergency authorization to use those tests at home as well. And that's going to be a slightly different model in terms of using an app for obtaining the test and reporting results. So more to come on that. So next slide. And I am now going to turn it over to my esteemed colleague, Dr. Thompson, to give us a couple updates, epi updates before we talk about vaccines. Thank you so much.
Wonderful. I'm just going to start sharing my screen here. Give me a moment. Okay, great. Hello again, everyone. My name is Corinne Thompson. I'm one of the epi data co-leads here in the COVID response. And I'll just go over very briefly some of the kind of top epi takeaways from the most recent week. So I may have talked at you a lot before, but just in case you haven't heard me, this is our DOH web page here. We have 3 different tabs here of information. I am going to focus mostly on the latest tab here, but we also have trends, which I'll focus on right at the end, and totals. And then also just to note again that you can download our data, which is updated every day at 1 p.m. here through this link, which is on GitHub. And not only do we have our data available for download, we also have extensive documentation about where our data come from and the kind of common misconceptions or frequently asked questions. So I encourage you to take a look at that if you're interested. So recently we have certainly been seeing an increase across the board. Percent positivity is increasing. We have this like funky milestones issue here. We're now showing the 7-day average here. You can see it's been pretty stable. It's slightly increasing recently. But all of our other metrics the last 7 days are higher than the weekly average from the past 4 weeks. Particularly hospitalizations and deaths. Just to note also, we are now, sorry, many technological things going on here. We are now reporting probable cases and probable deaths, probable cases as well, which is antigen positive, people with symptoms or confirmed exposure, or probable death here. So I'll just take you through some of the top takeaways here recently. This is our percent positivity map. So here, the darker the color, the higher the 7-day, the most recent 7-day percent positivity. We are seeing Staten Island is consistently high, although we think it has actually peaked, and I'll show you that in a second. Staten Island may actually be starting to decline, which is good news. South Brooklyn is this very dark red here. You can see Gravesend Homecrest has a percent positivity of 12%. Which is not good. We also see consistently Jamaica and Ozone Park are high. East New York is high. And unfortunately seeing Corona flushing again in Queens and then parts of the Bronx as well. We also have that information in a table that is sortable and searchable, so you can sort by the 7-day percent positivity. Sorry, these numbers are very small. But you can see again we have Gravesend Homecrest up here, Flushing in Queens, Borough Park in Brooklyn, and Richmond Hill also in Queens. And then just quickly, borough level information. Each one of these graphs is a borough. The borough level percent positivity is shown in green. The citywide percent positivity is shown, in dark blue. And then each of the zip codes is shown in a kind of gray. And it looks, again, a little bit like spaghetti, but the point is to try to see if there are any outliers. You can see 10464 did peak quite strongly at the end of November. So the one thing I'll say is, or two things I'll say. One is that there has been a stabilization of citywide percent positivity since around Thanksgiving, which is very good news. You can see in all the boroughs. And then especially interesting here, we're starting to see a decline in Staten Island, which is very good news. So you can see at the peak here it was about 9%, 10% borough-wide, and now we're back down to something like 7% for the borough of Staten Island. So that's good news, and I would encourage everyone to keep your eye on that as well. Also, in terms of cases, we've started to see a bit of a plateau, which is also good news. You can see here, this is the epi curve. Confirmed cases diagnosed by PCR are in blue. Probable cases are in gray here. And we're peaking, or we're stabilizing around 3,300, a 7-day average, which is very good news. Unfortunately, hospitalizations, as I don't need to tell you, are increasing, as well as deaths here are also increasing citywide, which makes sense given the lag. Also, you can see this information by borough if interested here. I won't spend too much time on that. The last thing I'll say on this page is just to show the testing here. So the people tested by molecular tests are shown in the light blue, and then people tested by this antigen tests here are shown in gray. You can see the antigen testing really started to take off in mid-October and has actually stabilized. We're seeing about 12,000, 13,000 people tested by day by antigen. And PCR testing has also stabilized. We're seeing roughly 55 to 60,000 people on average. Obviously, the weekends are much lower than the weekdays, but testing has stabilized, which is good. This is citywide percent positivity, something I keep a close eye on. You can see the 7-day average in the kind of bold line, and then the daily values are behind it in the light gray. Again, the weekend values are much higher because of hospitalized visits due to hospitalized patients who are more likely to be positive. You can also see this information by age. We are seeing a kind of dramatic increase in 13 to 17-year-olds. I encourage you to keep your eyes out. 13 to 17-year-olds and also 0 to 4-year-olds, they're now approaching 9 and 10%, which is much higher than the citywide average, which is still at about 6%. And I think I'll leave it there for now. The last thing before I leave this page, ED visits and admits are also increasing. You can see here the citywide average is for admits is in dark blue here. This is increasing, especially among our older New Yorkers here, 75 plus and 65 to 74-year-olds here. And then just to quickly point out in the trends page here, this is information from since the start of the outbreak. So the latest information is from the last 90 days or so, and then trends is the information since the beginning. So you can see our epi curve here as approaching probably May levels in terms of case counts, although again has stabilized in recent days. We hope that that continues, but we'll keep an eye on it. Testing, the one thing I did want to show you here is this is the turnaround time. So the turnaround time here we define as the time it takes from specimen collection to the time it takes to be reported to the health department. And we report out two different graphs here, the proportion that are within 2 days, the proportion within 1 day, hovering around 60% and 30%. And then also the thing I keep my eye on the closest is the median turnaround time. So it's still at 2 days, which is good. Hospitals are at turnaround time is typically around 1 day citywide. The urgent cares were going up, especially around Thanksgiving. The week of Thanksgiving, you can see their 75th percentile went up, or the citywide 75th percentile went up to 4 days. Urgent cares were the ones driving this. But now that has come down, so that's good news. So I think I'll stop there. Again, I encourage you to take a look at this website. There's a ton of information on here. And if you have any questions, please feel free to get in touch. Thank you.
Okay, hi, good afternoon, everyone. I am Bindi Crouch, and I am the Clinical Planning and Operations Lead for the vaccine section at the City Health Department. And I'm going to give you an update today on our COVID-19 vaccination program, as well as some really exciting updates in terms of vaccine development. Next slide, please. So I'll first be talking about the COVID-19, I'll first do a COVID-19 vaccine overview and talk about our planning, including vaccine timelines, availability and prioritization, as well as participating in the New York City COVID-19 vaccination program. We'll then move on to discuss the Pfizer-BioNTech COVID-19 vaccine, which received approval from FDA for emergency use authorization last week. Next slide, please. You can go to the next slide. Great. So just in terms of COVID-19 vaccine development and the approval process, so we really begin up at the top here with vaccine discovery as well as development by manufacturers. clinical trials then run into our phase 1, 2, and 3 trials that are performed by the manufacturer. These assess both safety as well as efficacy. A manufacturer, during an emergency or when there is not a current drug available for use, can then submit an application for an emergency use authorization of the product. The advisory committee for the FDA will then vote to determine whether or not they will recommend the emergency use authorization. The FDA ultimately will decide whether to issue the EUA. Following that, for vaccines in particular, our Advisory Committee on Immunization Practices, or ACIP, which is the body that brings us our routine immunization schedules, will then review the data and they will vote to determine whether or not they will recommend the vaccine for use here in the United States, and they will also provide guidance on its appropriate use. And then vaccine is shipped for use throughout the vaccination campaign. Next slide, please. So I'm just going to give a bit of an update. There are 6 vaccine manufacturers that have received funding from the federal program, Operation Warp Speed, to produce the COVID-19 vaccines. There currently are currently 4 products that are in phase 3 trials here in the United States. And I'm really going to focus on the first 2 of these. The first of these is the Pfizer-BioNTech mRNA vaccine. This is the one that we received emergency use authorization for and is currently in use here in New York City. The Moderna vaccine is also an mRNA vaccine. We'll talk about this a little bit today. However, I want to note that they first applied for emergency use authorization on November 20th. Yesterday, the VRBPAC recommended that the FDA approve the emergency use authorization, and we could see an approved emergency use authorization by this evening. The AstraZeneca DNA vaccine is also in trials here in the U.S., as well as the Janssen DNA vaccine. Next slide, please. I guess I jumped the gun a little bit on the last slide, but just to go over the timeline clearly, the Pfizer submitted an application for emergency use authorization back in November. The FDA issued that emergency use authorization on December 11th, and ACIP followed closely behind with recommending use for individuals ages 16 years and older here in the United States on the following day, December 12th. In terms of the Moderna COVID-19 vaccine, I think I said the wrong date before. Moderna submitted their application for emergency use authorization on November 30th, 2020. And as I mentioned, the Vaccines and Related Biological Products Advisory Committee, or VRBPAC, recommended that the FDA authorize the use of the Moderna COVID-19 vaccine yesterday. So we could see an approval this evening or later this afternoon. And the ACIP meeting again is planned for tomorrow afternoon. We do hope that we'll have licensed products sometime in 2021. Next slide, please. So given that there is limited supply of vaccine, vaccine is going to be allocated in 3 phases, and we really expect availability in 3 phases. Phase 1A, 1B, and 1C is when we expect to have limited availability and for it to be for the highest priority groups only. In phase 2, we're expecting there to be greater availability of vaccine, and at this phase, we expect that there will be vaccine for the general public. And then in phase 3, we expect to have enough vaccine so that we're able to shift to our routine vaccination infrastructure. Next slide, please. So just to focus a bit on phase 1 first. So again, this is when we will expect a limited supply for the country, and I will say that we've officially started phase 1 this past Monday with the delivery of the first vaccine here in the United States. And again, vaccine currently is available under an FDA emergency use authorization, so it is not yet a licensed product. And because we're expected to have limited availability, vaccine is set to be offered at a limited number of sites that can reach target populations. At this time, we have vaccine available in our hospitals. We'll soon be rolling out to the federally qualified health centers, and ultimately we hope to have vaccine in our large medical facilities as well as in our health department supported and health department run pods, which will be targeted for other high-risk healthcare personnel. Next slide, please. So phase 2, again, this is when we expect greater availability for the general public. During this time also, the New York City Health Department will continue to oversee vaccine distribution. However, we hope to see broad distribution and availability during this phase, and we will be expanding on existing vaccination infrastructure, including, though not limited to, our federally qualified health centers, our independent healthcare providers, pharmacies, both chains and independent, our urgent care centers, our hospitals and their affiliated ambulatory care centers, of course, our H&H facilities, as well as some potential sites run by the health department. And then in addition, we also may deploy community vaccinators to ensure that we can meet the needs of special populations. During this phase, we may see health department run points of distribution for the general public as well. Next slide, please. So because vaccine is limited now in phase 1, it's really important for us to have a strategy to allocate vaccine equitably. So the Advisory Committee on Immunization Practices has given our first recommendations, and they're set to provide more recommendations for allocation. Their guiding principles are to reduce the health impacts of COVID-19, to reduce transmission of COVID-19, to ensure vaccine safety and effectiveness, and to ensure the equitable allocation and availability of vaccine. In addition, we have a national vaccine allocation framework, and in this framework, groups are proposed for initial doses of vaccines, and these groups include high-risk healthcare workers as well as first responders with high risk of exposure. And really importantly, again, with this national vaccine allocation framework, equity is a cross-cutting consideration. Next slide, please. So the Advisory Committee on Immunization Practices has released an interim recommendation for what is being referred to as Phase 1A, which is where we are right now. So vaccination during Phase 1A should be offered to healthcare personnel, as well as staff and residents of long-term care facilities. Importantly, these considerations may be updated as additional information becomes available. Next slide, please. So we are expecting ACIP to provide recommendations for both phases 1B and 1C on Sunday. We're expecting additional target populations to include persons with increased risk of exposure to COVID-19, so those essential workers other than healthcare personnel, as well as persons with increased risk of COVID-19 complications. So this would include individuals over age 65, as well as persons with high-risk medical conditions. And again, I just want to point out that we expect to see these recommendations sometime Sunday evening. Next slide, please. So I'm going to turn now just to say a few words about our specific COVID-19 vaccination program here in New York City. And I just want to note that our vaccination program is really shaped around the expected or the current recommendation from ACIP on Phase 1A, as well as the expected recommendations for Phases 1B and 1C. And in addition, we work closely with New York State to ensure that our sub-prioritization within each phase are aligned and determined together. So we are taking a stepwise approach to facility enrollment to ensure that we're able to reach the priority populations. At this time, all of our 55 acute care hospitals and specialty hospitals are enrolled in our program. The federally qualified health center enrollment is almost complete, and we have opened enrollment for the remaining New York City vaccination providers back on December 7th, and enrollment remains open. I'll also note to ensure that we can reach long-term care staff and residents that almost all of the nursing homes, as well as the adult care facilities here in New York City, are enrolled in the CDC's Pharmacy Partnership for a Long-Term Care program. Next slide, please. So just in terms of enrollment in the program, medical facility networks as well as individual facilities are required to sign a federal provider agreement. So this agreement is with the federal Centers for Disease Control and Prevention. The provider agreement itself is completed in the New York City's Citywide Immunization Registry, or CIR. Once you are enrolled and once vaccine becomes available for your particular sector, vaccine will ultimately be ordered via the Citywide Immunization Registry. So vaccine will ship directly from the manufacturer or from the CDC distributor to the vaccine provider. Next slide, please. So I want to say a few words now about CIR reporting. So CIR reporting, it is now required to report all administered COVID-19 vaccine doses to the Citywide Immunization Registry within 24 hours of administration. And it's really important for those of you who see adult patients and may be administering COVID-19 vaccines. There is no patient consent required to report doses administered to adult patients. And the authorizations that include this information are the New York State Emergency Order from December 13th, as well as a New York City Commissioner Order from December 14th. And I'll point out that not only has the consent been removed, the consent requirement been removed for reporting of adult doses, it is required to report these doses. For any of you who are not registered with the CIR, we encourage you to sign up now so that you can begin the enrollment process into the COVID-19 vaccination campaign. We also would like you to begin ensuring that you're able to report all doses to the CIR, whether that's via the online registry, which requires manual entry dose by dose, or the preferred method, which is ensuring that you have a direct connection between your electronic health record and the CIR. We have information here on this slide for our team that works in CIR interoperability, and they will assist you with connecting your EHR to the CIR if you do not have that connection already. We just want to ensure that our providers are reporting both race and ethnicity in their electronic health records, as these are required fields when reporting COVID-19 vaccine doses administered. Ensuring that race and ethnicity are populated in your EHR can ensure that these information gets transmitted to the CIR. Next slide, please. So I want to just also talk a bit about vaccine adverse event reporting. Adverse events that occur in a recipient following COVID-19 vaccination should be reported to VAERS. So vaccination providers are required by the FDA to report the following that occur after COVID-19 vaccination under the emergency use authorization: any vaccine administration errors, any serious adverse events, any cases of multisystem inflammatory syndrome, and any cases of COVID-19 that result in hospitalization or death. And I'll also note that reporting is encouraged for any other clinically significant adverse event, even if it is uncertain whether the vaccine caused the event. Information on how to submit a report to VAERS is available at this link here and also by the 1-800 number on the slide. Next slide, please. I just want to say a word on how we will be monitoring vaccine administration and vaccine uptake here in New York City. We will have vaccination coverage dashboards that will track uptake and inform vaccination program decisions, such that if we see poor uptake in specific areas, we can have local responses to ensure that we're improving vaccination coverage in those areas. We will be monitoring vaccination rates alongside COVID-19 positivity rates. We'll be monitoring for vaccine safety trends. We'll be ensuring the equitable distribution following utilization of racial equity and public health ethics tools and frameworks. And then we'll, of course, do our post-incident response in order to learn and to improve as the campaign moves forward. Next slide, please. I'm going to turn now and just talk a bit about the Pfizer-BioNTech COVID-19 vaccine, which recently received the emergency use authorization. And I just want to take a minute first to point out that at this time, distribution of the Pfizer vaccine is really limited to hospitals who have the capability to store this vaccine. If you may have seen in the news or read about this, the COVID-19 vaccine by Pfizer-BioNTech must be stored at what are called ultra-cold temperatures in an ultra-cold freezer. In addition, these vaccines come in shipments of minimum orders of 975 vaccines, and at this time, we're really targeting the very first part of Phase 1A, which includes the high-risk healthcare providers. So again, at this time, distribution of the Pfizer product here in New York City is really limited to our New York City hospitals. And as we, hopefully by the end of this coming weekend, we'll have a product that is much more amenable to our ambulatory care practices and private providers for the future. So again, so on December 12th, just to provide the full ACIP recommendation here, they did issue as interim guidance the use of the Pfizer-BioNTech COVID-19 vaccine for persons 16 years of age and older for the prevention of COVID-19. Next slide, please. So I'm going to give a little bit of the data from the Phase 2 and 3 studies. This first slide really just shows the demographics. So they had over 43,000 participants in this trial. Again, this trial is still ongoing. We have interim results only. I do want to point out on this slide in particular the breakdown by age, and we can see in the orange box down in the right lower corner that about 21% of individuals in this study were over the age of 65. And of course, we know that this was a population that suffering severe complications due to COVID. Next slide, please. So we're going to show some of the efficacy data from the study, and these slides are actually available online from the Advisory Committee on Immunization Practices, and we have the links here. So I do encourage you to go back to that original slide deck to see more of the information. But this is for individuals without prior evidence of infection prior to 7 days. This is after dose number 2, and it really shows the first COVID-19 occurrence, more than 7 days after dose 2. And we see that in the vaccine group, we had 8 cases as compared to 162 in the placebo group, with a vaccine efficacy of 95%. And this is really exciting to those of us in the Bureau of Immunization. The interval, the confidence interval is quite narrow at 90.3 to 97.6%. But to see a vaccine efficacy this high is just really encouraging. The bar that was set by the FDA was really 50%. So to see something like 95% is just great news. Next slide, please. And just breaking down a bit by age, sex, race, ethnicity, and country. Country of trial. We really do see this high efficacy across the board in our age groups, our different sex groups, race, and ethnicity, and we did not see significant differences overall for any of these particular demographics, which is also exciting. Next slide, please. I also just wanted to show you here, highlighted in the orange boxes, our vaccine efficacy based on comorbidity. And I do want to point out that, again, we're seeing high vaccine efficacy even in the case of chronic medical disease. So hypertension in particular on the bottom, we see vaccine efficacy of 95.4%, diabetes, vaccine efficacy of 95%, and as well as our chronic pulmonary disease at 93%. I will say that the one place that we did see lower vaccine efficacy is in any malignancy. Next slide, please. So this is just looking at specifically severe disease. So this is severe incidence of severe disease following vaccination or placebo. In this particular slide looks at the CDC definition based on hospitalization, admission to the ICU, intubation or mechanical ventilation, or death. On the bottom, we see after dose 1, where we saw 1 case of severe illness in our vaccine group as compared to 14 in the placebo group. And then it's actually on the top here is more than 7 days after dose 2, where we saw 0 cases in the vaccine group compared to 5 in the placebo group. So I think that, this is just, it's really exciting to see that even if we have an individual who has developed COVID after vaccination or despite vaccination, we do see the ability to prevent severe complications from COVID in the vaccine group. Next slide, please. So I know there's been a lot of talk about safety, and I do want to point out to all of you providers that we do see some high reactogenicity following vaccination with the Pfizer vaccine. What we've heard from reports is that it's actually quite similar to receiving a Shingrix vaccine, for instance. And for those of you who see adult patients, you're probably familiar with the Shingrix vaccine and the post-vaccination side effects. But this is based on data from e-diaries in a subset of the population, so just over 8,000 individuals. This is actually broken down here into the 16 to 55-year-old, as well as the greater than 55-year-old population. And we can see here dose 1 on top and dose 2 on the bottom. This slide looks particularly at local events, so pain at the injection site. And we do see, an 83% pain at the injection site in our 16 to 55-year-olds. In the vaccine group, as well as 71% in our vaccination group in the greater than 55-year-olds, just a little bit lower for our local events in dose number 2. Next slide, please. I know this is quite a busy slide, but I still really wanted to show it. I know that there's a lot of talk about systemic reactions following vaccination. This slide looks particularly after dose number 2, and this again is broken down into the 16 to 55 as well as the over 55-year-olds. And I'll just point out, so we have fever on the starting on the left-hand side, and certainly we see some fever following vaccination at 15, almost 16% here in the 16 to 55-year-olds, and almost 11% in the greater than 55, but where we really see even higher incidence of side effects with fatigue, headache, and chills. And we can see in the 16 to 55-year-olds even greater than that in the 55-year-olds and older. We also see muscle pain and joint pain here. So we do see that that this vaccine does have quite a reactogenicity profile. Next slide, please. And this is just looks at days, and I think this is important, especially now that we're vaccinating mostly healthcare personnel. So we do tend to see these events more commonly after dose 2 than after dose 1. So I really just showed you the slide for dose 2 here. And what I want to point out is that day 1 is considered the day of vaccination, with day 2 being the first day after vaccination and beyond. So we see a preponderance of these systemic events occurring on day 2, and then to a lesser extent on day 3. And so this really will come up for those of you who yourselves, of course, are healthcare personnel, and if you decide to be vaccinated once vaccine is available to your priority group, but as well as to our healthcare systems who are vaccinating their own healthcare personnel, and to really look at potentially staggering vaccination in your healthcare facilities to anticipate potential post-vaccination side effects on day 2, and also to consider vaccinating, for instance, on the day before a day off. Next slide, please. So I'm just going to go through some clinical recommendations, and I'll speed up a little. I do want to note that, of course, this is specific to Pfizer. We're expecting that clinical recommendations will also come out after the Moderna vaccine. So the Pfizer vaccine is an IM administration. The dose is 0.3 mLs, and it is a 2-dose series administered 3 weeks apart. As with other vaccines, there is a 4-day grace period, so that anything administered between starting at day 17 and beyond is valid. Very similar to our other vaccines, there is not considered to be an upper limit for the duration between doses. So if more than 21 days have passed since the first dose, you should administer the second dose at your earliest opportunity, and you would never repeat the first dose. And just to point out that both doses are necessary for protection. Next slide, please. This is not typical. We usually say that you can administer almost all vaccines at the same time. Particularly for this vaccine, you should not co-administer with other vaccines. You should wait a minimum of 14 days before or after administration with any other vaccines. However, if you're inadvertently administered this vaccine within 14 days of another vaccine, you do not need to repeat the doses of either of the vaccines. Next slide, please. And I know that this is a topic that everybody has been quite interested in. So in terms of vaccinating individuals with a history of SARS-CoV-2 infection, you should offer vaccination regardless of history of prior symptomatic or asymptomatic SARS-CoV-2 infection. Viral testing for acute infection is not recommended for vaccine decision making. Serologic testing for prior infection is also not recommended for vaccine decision making. You should defer vaccination until recovery from any acute illness, if a person was symptomatic. And of course, you should defer vaccination until any criteria for discontinuation of isolation is met in individuals with current infection. Next slide, please. For individuals who are potentially in a quarantine period because they've had a known SARS-CoV-2 exposure, this really depends by setting. In the community, or if there was an outpatient, you would defer vaccination until the end of the quarantine period, just to ensure that the individual is quarantined and to avoid any possible exposures of them coming in for a vaccine while in a quarantine period. In congregate healthcare settings, this changes a little bit. Vaccination is recommended in order to ensure that you don't miss out on vaccinating an individual, and because it likely would not lead to any additional or new exposures given that the individual is currently in a congregate healthcare setting. In other congregate settings, individuals may be vaccinated specifically to avoid delays and again to avoid missed opportunities, but you should take precautions to limit exposure to other residents or non-essential staff. Next slide, please. For immunocompromised persons, individuals, of course, may be at increased risk for severe COVID-19. We currently do not have any data to establish the safety or efficacy in individuals who are immunocompromised. These persons may be vaccinated unless otherwise contraindicated at this time. Counseling should include the unknown safety and efficacy in this population, as well as the potential for a reduced immune response. And to point out, because of that potential reduced immune response, it would be important, as it will be for all individuals, to continue to follow all guidance to protect against COVID-19. Next slide, please. So pregnant persons. So there is no data on safety in pregnant individuals. However, mRNA vaccines are not live vaccines. They also are degraded quickly by normal cellular processes, and they do not enter the nucleus of a cell. So it is expected that mRNA vaccines would be safe in pregnancy. In addition, we know that there is an increased risk of severe illness in a pregnant individual if they contract COVID-19, and there may be an increased risk of adverse pregnancy outcomes, such as preterm birth. So the current recommendation is that if a person is a part of a group, for instance, high-risk healthcare personnel, that is currently recommended to receive a COVID-19 vaccine and is pregnant, the individual may choose to be vaccinated. And the CDC, of course, does recommend and encourage informed decision-making in consultation with a healthcare provider. Next slide, please. In terms of breastfeeding and lactating persons, there currently is no data on safety in lactating persons, nor the effects of mRNA vaccines on the breastfed infant or on milk production and excretion. mRNA vaccines are not, again, considered live virus vaccines, so they're not thought to be a risk to the breastfeeding infant. And again, if a lactating person is part of a group, for instance, healthcare personnel currently recommended to receive a COVID-19 vaccine, they may choose to be vaccinated. Next slide, please. I'm just going to talk again just a bit about the reactogenicity. So for those of you who may be vaccine providers, but also for those of you who may be receiving vaccines yourself, it is really important to recognize, and if you're vaccinating others, to counsel recipients about the expected local and systemic post-vaccination symptoms. And so we showed this in the data. They include fever, fatigue, headache, chills, myalgia, and arthralgia. So unless an individual develops a true contraindication to vaccine, you should really encourage them to complete the series. An antipyretic or analgesic medication may be taken for the treatment of symptoms following vaccination. Next slide, please. So just in terms of prevention of COVID-19 post-vaccination, and again for yourselves if and when you're vaccinated, and for anybody that you're vaccinating. As with most vaccines, protection is not immediate. It generally takes 1 to 2 weeks following dose number 2 to be considered fully vaccinated. And again, no vaccine is 100% effective. So it's important to continue to follow all guidance to protect yourselves or your patients as well as others, including to stay home if you're sick, keep physically distanced, wash your hands frequently, and wear a face covering. Next slide, please. I do want to point out the contraindications. Their severe allergic reaction, for instance, anaphylaxis to any component of the vaccine is a contraindication to vaccination at this time. You should ensure, of course, as with all vaccines, that appropriate medical treatment for managing immediate allergic reactions is available. Next slide, please. So there have been reports of anaphylactic reactions in persons vaccinated outside of the clinical trials. At this time, because of this, a severe allergic reaction to any vaccine or injectable therapy is a precaution to vaccination at this time. And important to point out, seasonal allergies, allergies to foods, to oral medications, allergies to pets, these are not included as a precaution. Additionally, family history of anaphylaxis is not included as a precaution. However, persons with history of anaphylaxis, should they decide to be vaccinated, should be observed for a full 30 minutes. All other persons are recommended to be observed for 15 minutes. Next slide, please. I'll just show you some materials. We have a really great new website up for our vaccine providers. Next slide, please. We have multiple, there are multiple resources now available that kind of came out over last weekend. Expect that some of these materials will be updated over the coming weekend. So next Monday and Tuesday, we expect to see another slew of materials from the CDC and others. Next slide, please. And I just, of course, want to point out again, so we do have our public-facing website now for individuals seeking information about COVID vaccine. We also have the same for providers. We really encourage you to, to point your patients towards our public-facing site, to really get accurate information. And if you need assistance, we're here. And I will stop there. And I know that we're a bit over time here.
Great. Thank you so much, Dr. Crouch. We have a lot of really great questions coming in. So if you don't mind, we can start going through a couple of those. So you definitely started to touch on it, but there are a couple questions about what the plan is for independent providers that are not already slated for receiving the vaccine through hospitals or federally qualified health centers to receive the vaccine for their staff.
Right. So we are working off of we're within phase 1A healthcare personnel. There is a sub-prioritization based on risk of exposure to COVID-19, and as well as I mentioned, due to the specific properties of the vaccines that are available at this time, as well as due to the limited amount of vaccine that is available. However, once we get to your priority group, say, potentially ambulatory care, ambulatory specialty care, if the site at which you work has not received vaccine, we are working on other options for you to be vaccinated. That would include at the hospitals, at our federally qualified health centers, as well as at pods that the city will likely be standing up specifically for healthcare personnel. And we, in addition, we're really hoping to get started with our pharmacy vaccination program soon. Again, we're really waiting for this Moderna vaccine. Thanks, Mary.
That's great. Thank you very much. And then we had a couple questions just looking for some more details about about costs for the vaccines. How is the cost going to be covered? Yeah. Is it free? Is it going to be charged to insurance versus no insurance, et cetera? So anything to share?
Sure. So for any of you who are familiar with the Vaccines for Children program, it actually runs similarly. So the vaccine is actually paid for by the U.S. government. All doses of the vaccine at this time are paid for by the federal government. We get an allocation here to the city, and then we manage that allocation and ship it out to our providers. So our providers, all vaccine providers, receive the vaccine at no cost, and then providers are able to bill for the cost of administration. And so since at least since the Pfizer vaccine is now an ACIP recommended vaccine, the Affordable Care Act does require that insurance companies cover this vaccine, so you could bill for administration. For individuals who don't have health insurance, there is a HRSA program that you can recuperate the cost of administration through the HRSA program. So the idea here, I think that this is just really exciting. The idea here is that there will be no cost to individuals, so that we really can improve access to vaccines. Next, Mary.
Okay. We had a really great question, equity-related question. So in terms of the vaccination prioritization, where do individuals experience, mainly about congregate settings such as homeless shelters and incarcerated individuals that are, more vulnerable populations, and where do they fall into the prioritization?
Yeah, so we're expecting more information about this over the weekend, but likely at the very top of 1C or towards the end of 1A. I think that we have to think of this a little bit as a spectrum. So, the health department as well as our partner agencies are actively planning for congregate settings, and that includes for the shelters for individuals experiencing homelessness, as well as within our prison and jail system. So we are actively working on those plans. So thanks for that question. Next question.
Great. Sorry. It's been a long week for you. So for this. So there was a good question about for the trial, the phase 3 trial, were the patients subject social distancing, staying at home, or were they moving about in terms of, potential exposure risk during the trials?
Yeah, I'd have to look into that more, but I know that there were for specifics, I'd have to look back over the trials, but they were, they were screening individuals for participation, and one of the variables that they were looking at is the amount that you leave your home, the amount that you go to certain locations. So there, but of course that there were a lot of requirements in place in a lot of locations. So people would be wearing masks. But yeah, so they had to take that into consideration for sure. I can take another if we have time. I'm happy to stay on a minute, but.
Great. So there was just a question about timing for when the Moderna vaccine might be coming, and I think Dr. Rosen clarified that would be expected to begin being shipped next week, the week of December 21st. And then there was a question about which vaccine will be recommended for school-age children.
So at this time, neither vaccines are recommended for school-age children. The Pfizer product is recommended down to age 16 right now. Pfizer has started enrolling individuals ages 12 and older, though they're just really at the start of that process. Moderna does not and has not yet enrolled pediatric patients. So, we think that we'll be seeing some data from Pfizer over the next several months, and expecting that the other trials will begin enrolling children also. So at this time, we do not have a vaccine for anyone under age 16.
Okay, and I think.
Yeah.
Oh, I was just going to say last question I think would be really helpful for the group would be for those that are having the pharmacy giving the vaccine to their residents or staff, who would be expected to report into the CIR, the dose?
This is the beauty of the CDC Pharmacy Partnership Program, and this is why we've really encouraged all of our long-term care facilities, our SNFs and our ACLs, ACS, ALFs, to participate. It's an end-to-end program covered by the federal pharmacy partners. If you have another congregate setting, though, a separate congregate setting, there's not a federal program for you, but we are working on matching congregate settings to vaccinators. And if you have a vaccination team coming in, the vaccinators are responsible for enrolling in the program and for reporting vaccine to the CIR. So
great.
Great.
Yeah, that's great. I know we have so many excited questions, but I think unfortunately we're out of time. But I promise you in the coming weeks, not all will be revealed, but much more will be revealed. So thank you so much for your very wonderful and enlightening presentation. And to everybody on the line still, we really wish you a safe and happy holidays if you are celebrating. And we look forward to having further sessions in the new year. So thank you very much. Have a great day.
Thank you.